Thank you. Hello, afternoon, everyone. So I didn't want to give a standard textbook lecture on syphilis. I've tried to focus on the controversies, particularly around diagnosis and treatment, and also based on various clinical queries I've received over the years. I hope it will be an interactive session. So let's see how we go. All right. So, okay, I'll be focusing on global and local epidemiology. I'll discuss aspects of microbiology, some case reports and diagnostics and treatment around those cases, pathogenesis and natural history of infection, follow-up of cases, at what interval should they be followed up, what tests should be done, and what are the prospects for a vaccine. I've started off with a bit of history because it's so fascinating. There are lots of theories on the origins of syphilis and how it spread globally. It was brought from the New World, the Americas, to the Old World, to Europe by Columbus in 1493. This is what we are told, but it is debated. And then in 1495, an epidemic of what was called the Great Pox broke out among the soldiers of Charles VIII of France as he invaded Naples. And this was the first of the Italian wars. And as the army disbanded, his soldiers took the disease home with them. And by the end of 1495, it had spread to other European countries such as France, Switzerland, and Germany. And by 1497, syphilis had reached England and Scotland. And so Voltaire wrote, on their flippant way through Italy, the French carelessly picked up Genoa, Naples, and syphilis. Then they were thrown out and deprived of Naples and Genoa, but they did not lose everything. Syphilis went with them. The name originates from a Latin poem composed by an Italian poet, Fracastoro, about a mythical shepherd named Syphilis, who looked after the flocks of King Alcithous. And when a drought affected the land, he had insulted the sun god, Apollo, and the god had retaliated by afflicting Syphilis and his people with a disgusting and odorous new disease. Okay, and it's been called a variety of names over the years. So people have named it either after an enemy or a country that they thought was responsible for it. And I like the Scottish name the best, the Grand Gore. If we look at global epidemiology, these are the latest WHO incidence estimates for the 4 curable STIs. This is for 2020 among adults aged 15 to 49 years. You can see that the African region has the highest incidence, 96 million, followed by the Western Pacific region. And if we look at incidence estimates stratified by gender, you can see that there were 7.1 million incident cases of syphilis in 2020. We do have some local epidemiological data. We modeled South African incidence estimates using the STI spectrum tool. And these were based on prevalence data in adults attending family planning clinics and also from household and antenatal surveys. And the general population incidence estimate for 2017 among both men and women, 71,000 cases for syphilis in South Africa. So what about the causative organism? Treponema pallidum subspecies. Pallidum is the only cause of venereal syphilis. It is a motile spirochete. It has periplasmic flagellae at either end, and it moves using a corkscrew motility using these flagellae. It cannot be visualized by bright field microscopy because its outer membrane lacks lipopolysaccharides. So you need to use dark field microscopy using a dark field condenser that is attached to the microscope. And this blocks direct light, and it allows only oblique light rays to pass through the specimen. And these light rays then reflect off the outer membrane and the internal organelles. And so you can see these bright spirochetes against a dark background. You do need a very experienced microscopist to observe these organisms, and usually obtained from active lesions. So you need to get exudate. Within 20 minutes of specimen collection, you would have to observe for the characteristic morphology and motility. It's only really suitable for genital ulcer specimens because oral or rectal specimens may have commensal, non-treponemal or treponemal spirochetes that are not treponema pallidum. The organism does have abundant lipoproteins, but they're mostly found below the surface. So they're not surface expressed or exposed. It's really a stealth pathogen because of this. And so it will elicit a less marked inflammatory response. And that's how it's able to avoid the host immune response and spread and disseminate widely. It's an obligate parasite of humans. There are no animal or environmental reservoirs. What about transmission? We've already seen that it has a worldwide distribution. Vast majority of infections spread by sexual intercourse, also through direct contact, so kissing or touching active lesions, and we'll see what some of these lesions are. Vertical transmission can occur transplacentally or via the birth canal through contact with active lesions during passage through the birth canal. What about blood transfusion? So transmission via transfusion is rare because donors, as you know, are screened. And the organism also cannot survive outside the human body in blood that is refrigerated for more than 72 hours. Accidental inoculation is also quite rare. What about the portal of entry? So penetration of intact mucous membrane or abraded skin. It attaches to epithelial cells and extracellular matrix components like fibronectin and laminin. The infectious dose varies. So as few as 4 spirochetes can generate an infection, and the doubling time is long, about 30 to 33 hours compared to E. coli, for which the doubling time is about 20 minutes. And this is important when we consider treatment, and we'll discuss this later. The incubation period on average is about 3 weeks, but it varies from 3 to about 90 days, dependent on the inoculum. So the larger the inoculum, the shorter the incubation period. So let's discuss the first case of a 45-year-old male who presented with a history of oral cold sores and multiple penile ulcerations, which were pruritic and slightly tender. He thinks they were caused by his new swimwear. He had no constitutional symptoms. He was last sexually active 4 months ago. Serum HIV negative, RPR negative, but HSV 1 IgG positive. And a diagnosis of genital herpes was made, treated with oral valdecyclovir, then topical acyclovir and hydrocortisone twice daily. He had no inguinal lymphadenopathy, no perianal lesions. And you can see multiple small punched out shallow ulcers on the penis and this oral lesion as well on the lip. So what is this? Obviously it's primary syphilis. And here's a controversy. It's typically painless and it's typically solitary, and that's how it's described in textbooks. But often the ulcers may be painful and multiple, particularly in HIV-infected persons and MSM. And it's very important to also examine for perianal lesions and oral lesions. And these lesions are accompanied by painless or minimally tender rubbery inguinal or cervical lymphadenopathy. So if the lesion is in the mouth, the patient may present with cervical lymphadenopathy, and often primary syphilis may coexist with manifestations of secondary syphilis, particularly in HIV-infected patients. So how would you make a laboratory diagnosis of primary syphilis? How would you confirm the diagnosis? How would you make a definitive diagnosis? And you can type answers into the chat box, or is it the Q&A section, Jeremy?
Yeah, Q&A is probably a bit better, but either one is fine.
Okay. And this was a case of primary syphilis, and the way they made a diagnosis was through histologic evaluation of the biopsy. So they did a biopsy of the ulcer from the penis, and this demonstrated numerous plasma cells and spirochetes consistent with syphilis. How would you make a definitive diagnosis?
Two replies so far. So one person suggested an RT-PCR on a swab from the lesion.
Right.
And the other person suggested an RPR. If that's positive, then TPHA. And then we've got a third one that's just come through, or dark field microscopy.
Dark field microscopy. So dark field microscopy is rarely offered. I'm not sure whether any NHLS lab offers dark field microscopy. We don't at the NICD. It can be quite subjective, and you need a very experienced microscopist and very fresh specimens, because as I said, you need to observe for the characteristic morphology and motility. So you need to observe within about 20 minutes of specimen collection. And you'd need a microscope with a dark field condenser. So we will not offer it, but certainly you could do PCR. And there are in-house and commercial PCR assays for Treponema pallidum. We do offer an in-house assay. And we look for the gene encoding a certain protein, the TP47 protein. And there are we have commercial assays as well. What about syphilis serology? So serum RPR will be positive in about 75 to 85% of cases. And in very early primary syphilis, the sensitivity is lower. Usually a specific treponemal assay, particularly an automated assay, will be positive sooner than the RPR. It's more sensitive than RPR in early syphilis. But again, 3 to 4 weeks or so into chancre development, you would expect a positive treponemal and RPR assay if it is primary syphilis. So just remember that the RPR may be negative in very early primary syphilis. And you would confirm the diagnosis using a T pallidum PCR assay. But as you know, in South Africa, we treat syndromically. So if a person has been sexually active within the preceding 3-month period and presents with a genital ulcer, you would treat for primary syphilis. And if we look at our local epidemiology, you can see that between 2007 and 2015, syphilis was the second most commonly detected STI pathogen, and it was responsible for about 10% or slightly less of genital ulcer disease. The commonest cause, as you know, is HSV, responsible for about 50 to 60% of GUD. But in recent years, we can see that the relative prevalence of Treponema pallidum has increased. So in 2019-2020, it was 24%. We'll discuss the reasons for this. Okay, what about case 2? Right. It's a 59-year-old male who presented with fever, chills, and progressive submental swelling, which had been present for the past 1 month. Also complained of dysphagia, sore throat, and significant weight loss. Is sexually active with 1 female partner in the past year. On examination, there was submental lymphadenopathy and a non-pruritic erythematous maculopapular rash over the chest and hyperpigmented macules involving the lower limbs, the palms, and the soles, and an oral lesion on the hard palate, as you can see right here. He had no genital lesions. He was HIV negative. And what's the diagnosis here? And why do we call syphilis the great imposter or the great mimicker? Okay, so what's the diagnosis?
We've got 1 vote for secondary syphilis.
Okay, right. Yes.
Another vote for secondary syphilis, yeah.
Yeah, so this is a case of secondary syphilis. The commonest manifestation in secondary syphilis is a rash. In up to 75% of cases, it can be maculopapular, it can be pustular, rarely necrotic. Sometimes you get a very severe ulceronodular rash, particularly in HIV-infected patients. Then you have condylomata lata, these moist plaques in the genital region, commonly, or the perianal region, and they're highly infectious, and they occur in a minority, in only about 10%. You may also have snail track ulcers, and these are irregular linear erosions, which can occur on the hard palate, on the buccal mucosa, and or erythematous mucus patches. And these mucus patches appear as raised round or oval plaques, and they're generally covered by a delicate white pseudomembrane. You can get snail track ulcers or mucus patches in the mouth. You also have them on the lips, and alopecia. And the rash often involves the palms and the soles. And it's called the great imposter because there are many differential diagnoses, such as, can people list some of the differentials, which may be infectious or non-infectious?
We've got chicken pox from someone, Kaposi sarcoma from someone else.
Okay.
Another vote for Kaposi sarcoma.
Okay.
Autoimmune, such as
sarcoma, does it present as maculopapular lesions commonly, or pustular lesions?
So I can answer on behalf of hopefully the people who are typing in. So no, certainly not pustules. Papular sometimes, macular occasionally, but certainly not pustular. Okay. We've got another vote for papular, I suppose, for KS.
Okay, lots for KS. What about more? No, I shouldn't say more common infections. What are some of the other STI causes of maculopapular rashes? Or pustular rashes?
We've got HPV from someone, gonorrhea.
HPV will cause warts, genital warts, perianal warts, certain genotypes of HPV. So won't typically present with maculopapular rash, but may mimic condylomata lata. Yes. What else? Sorry.
Gonorrhea is another option.
Okay. Yeah.
I suppose probably more disseminated gonococcal infection.
Yes, that's right.
Hand, foot, and mouth disease, another one that's come up.
Yeah.
HIV seroconversion.
Right.
Another vote for herpes, I presume herpes simplex.
Okay, so this is what I have. A disseminated gonococcal infection, certainly acute HIV infection, can present with rashes involving the palms and soles, and also oral lesions and lymphadenopathy, because you can get generalized lymphadenopathy in secondary syphilis. Disseminated meningococcal infection, although the course will be very acute. Tick bite fever, certainly need to think about that. Rickettsial infection, because the rash can also involve the palms and soles. Remember, I said rash is the commonest manifestation of secondary syphilis in up to 75% cases. What about adult measles? Then drug eruptions, particularly with beta-lactams and sulfonamides, also involve the palms and soles. Eczema, psoriasis, pityriasis rosea, which may be precipitated by a viral infection. So that's what I had on my list, but certainly the other suggestions were also valid. Okay, so what would you expect with syphilis serological testing using the reverse testing algorithm, A, B, C, or D, or E? So this is a case of secondary syphilis, remember. Okay.
Just give it a little bit longer for people to vote.
Right.
All right, I'm going to close it in 5 seconds.
Right, so you would almost certainly expect the specific treponemal assay to be positive because remember, secondary syphilis represents disseminated infection. So treponema pallidum has spread to multiple organs via the bloodstream. So there's hematogenous spread. So because of that, you'd expect the TPA to be positive, and also because it's well into the infection. This is about several months into infection. You would also expect the RPR to be positive in almost 100% of cases. So the serology would be a very useful diagnostic modality. So syphilis serology is what you would do to confirm the diagnosis of secondary syphilis. How would you treat this patient? A, B, C, D, or E? So would you use doxycycline for 14 days? What would you prefer? Benzathine penicillin for 3 weeks, doxycycline for 28 days, or a stat dose of benzathine penicillin, or none of the above?
Okay, we'll give people about 10 seconds.
Okay, so most people have chosen benzathine penicillin for 3 weeks, weekly for 3 weeks. The correct answer is actually benzathine penicillin stat 2.4 million units, because secondary syphilis is early syphilis, and a stat dose of benzathine penicillin is adequate for both primary, secondary, and early latent syphilis. So within 2 years rather of acquisition of infection. So for early syphilis, you could give just a stat dose of benzathine penicillin. You could also give a course of doxycycline for 14 days, 100 milligrams BD, as an alternative if benzathine penicillin is unavailable. So those are the 2 correct choices. And we'll discuss treatment in a bit. So here's case number 3. As part of the first antenatal visit screen, you send a blood specimen from a 30-year-old patient for syphilis and HIV testing. She's well and has not been previously tested or treated for syphilis. No other pertinent history available. Here's a result of a syphilis screening test, and again, a reverse screening algorithm was employed, and the automated TP antibody assay is reactive. What is the best interpretation of this result? No laboratory evidence of syphilis, or is it consistent with an active or current syphilis infection, or with a past syphilis infection, or with syphilis infection at an undetermined time, current or past?
Okay, 5 more seconds.
Okay. So most people have chosen consistent with syphilis infection at an undetermined time, okay, which is absolutely correct, because specific treponemal antibodies remain positive almost lifelong following infection, and they could represent current infection or previous infection that has been successfully treated. Because these antibodies will not decline or are not expected to decline following successful treatment for syphilis. All right. These are the final results. So automated TPAB reactive, RPR reactive with the titer of 8. What is the best final interpretation based on all the results? A, B, C, or D? So this is a pregnant female who has been screened as well. Nothing significant on examination.
Okay, another 10 seconds.
Mm-hmm. That's absolutely right. Most people have said consistent with an active or current syphilis infection, because the non-treponemal assay, which is the RPR, is reactive. The titer is 8. It's not very high, but this female has not previously been tested or treated for syphilis. So it's imperative that you consider this to be an active or current syphilis infection and treat this pregnant female to prevent congenital syphilis. Okay. What is the diagnosis here? What stage of disease is this? You can start typing in.
I've got 1 vote for tertiary so far.
Okay, tertiary.
Another vote for primary.
Primary. So primary syphilis would manifest generally as genital ulcer disease. Okay. May have oral lesions, may have perianal lesions, but you would see manifestations of disease.
And then we've got 3 votes for latent.
Latent.
5.
Is it early latent or late latent syphilis? It is latent syphilis, because this female is asymptomatic. There are no signs or symptoms of infection. But we do not know whether this is early or late latent syphilis, because we do not know when she acquired the infection. If she had acquired it within the past 2 years, we would define it as early latent syphilis. But we don't know that. So we would simply say latent syphilis, and that is correct. The risk of mother to child transmission of syphilis is highest when the mother has early syphilis, so within the first 2 years of infection. And it is rare after 4 years of infection. How would you treat this patient? A, B, C, or D? A, B, C, D, or E, sorry. And you can choose more than one response here.
Okay, another 10 seconds. I think the poll itself probably just allows you to choose one option, but we can see.
Oh, okay.
So just use
all
the
right.
best option.
Okay, single best then.
Another 5 seconds.
Okay, and that's right. Option D is correct. Because this is latent syphilis, no signs or symptoms, you would give a prolonged course of benzathine penicillin, so 2.4 million units IMI weekly for 3 weeks. And you could also give amoxicillin and plus probenecid to prolong the blood levels of amoxicillin. if benzathine penicillin is unavailable. And this is in our standard treatment guidelines as alternative therapy in pregnant women. Amoxicillin and probenazid for 28 days. It needs to be doctor prescribed, and the pregnant female would need to be followed up closely after treatment for serological response. Okay. What about azithromycin? Not really recommended for any stage of syphilis, and certainly not for latent syphilis. It has been used in early syphilis, but there has been rapid induction of resistance following use through chromosomally mediated 23S rRNA mutations. And it also does not treat syphilis in the fetus because it doesn't effectively cross the placental barrier. So azithromycin is not an option in pregnancy. Alternatively, ceftriaxone has been used in early syphilis only. So early latent syphilis, you could give ceftriaxone 1 gram IM daily for 10 to 14 days. But really only penicillin is known to reliably treat syphilis in the fetus. What if there's penicillin hypersensitivity? You need to take a good history to confirm that there is actually hypersensitivity to penicillin. And then ideally referral to an allergist for skin testing, or you can give a graded oral penicillin challenge. So a 250 milligram dose of amoxil and observe for 1 hour, preferably in a hospital facility. Okay.
Ranmini, one question that just came up in the Q&A now, which is probably worth answering now. That one person just wants to know what's the definition of early versus late. Is it 1 or 2 years is the question.
So some authorities say 1 year. I think the CDC says 1 year, the WHO says 2 years. And generally we define it as infection within the first 2 years of infection is early syphilis. And we'll talk about why that is. And anything after the first 2 years of infection would be defined as latent syphilis, if there are no signs and symptoms. And we'll talk about why that is, why that distinction needs to be made. Is that okay?
Yeah, perfect. Thank you.
All right. So T. pallidum, what about macrolide resistance in South Africa? We looked at 96 Treponema pallidum strains between 2010 and 2018. This is from our genital ulcer syndrome surveillance. So these were strains that caused primary syphilis. And you can see that we started detecting resistance in 2013. And this was due to a 23S rRNA mutation, A205HG. It's a specific mutation, adenine to guanine. And the overall prevalence of macrolide resistance over these years was 23%. There was an association between macrolide resistance and T. pallidum strain type. It was associated with strains 14DF and 14DG. Some of these strains are also known to be associated with neurosyphilis. But there was no association between macrolide resistance and HIV co-infection, and approximately 50% of these participants were HIV co-infected. And if you have a look at the trend, you can see that there was a significant increase in macrolide resistance prevalence over the surveillance period, especially between 2017 and 2018, compared to 2015 and 2016. And yeah, several T. pallidum strain types were identified. So there was a vast diversity of strain types. And this is just in Gauteng. We looked at 49 T. pallidum strains in Gauteng because we had a continuous data set for Gauteng. We did annual surveillance between 2011 and 2018. And you can see that resistance really started increasing after the introduction of the 1 gram azithromycin dose to the national STI treatment guidelines for genital discharge. And we find that a significant proportion of patients presenting with genital ulcer disease also have genital discharge. So they may receive azithromycin. And so this may be due to selection pressure as well. So we would never consider using or incorporating azithromycin into treatment algorithms for genital ulcer disease. What about dosing of benzathine penicillin G in pregnancy? This was something that was recently included in the US CDC guidelines. They say that although there's not much evidence for this from what I can see, they say additional therapy is beneficial for pregnant women to prevent congenital syphilis. So for women who have primary, secondary, or early latent syphilis, a second dose of benzathine penicillin can be administered 1 week after the initial dose. We say only really one dose is necessary to prevent congenital syphilis, but they recommend inclusion of a second dose if possible. They also say missed doses, more than 9 days between doses, so a dosing interval of more than 9 days is not acceptable for pregnant women receiving therapy for late latent syphilis. An optimal interval between doses is 7 days, and a pregnant woman who misses a dose of therapy should have the treatment repeated in full, so the full course of therapy repeated. The WHO says that the interval between consecutive doses of BPG should not exceed 14 days. And if it does, then the course of the 3 weekly doses needs to be repeated in full. So we can see why this is, and I tend to agree with the WHO. I think the CDC is being extra cautious, but we'll discuss this when we discuss PK/PD parameters. What about partner treatment? If the index case is diagnosed with early syphilis, so that's primary, secondary, or early latent syphilis, and the sexual contact has occurred in the past 3 months, then the partner should be treated empirically, regardless of serology. If the index case has latent syphilis, particularly late latent syphilis or syphilis of unknown duration, ideally the partner should be evaluated serologically prior to treatment, particularly if it's a long-term partner. We're all familiar, I'm sure, with the reverse testing algorithm, where an initial treponemal assay is performed, and it's usually an automated assay. If it's non-reactive, we say no active syphilis, no further testing required. If it's reactive, we reflexively perform a second test, which is non-treponemal, so generally a manual RPR. And if the RPR is non-reactive, say no active syphilis or possibly very early or late stage syphilis. And so clinical correlation is very important. If it's reactive, we go on to do an RPR titer, quantitative RPR. A titer of greater than or equal to 16 almost certainly defines active syphilis. If it's less than 16, so 8 or lower, there are several possibilities and we can discuss those. Automated RPR has recently become available, and this is an FDA-approved test. It's fully automated, the AIX 1000 system. 192 samples can be processed in 90 minutes. And it is, the manufacturer is Gold Standard Diagnostics. They're based in the US. And this can also give semi-quantitative results. So titers from 2 to 256. Not available in South Africa yet. Okay, so what are some of the possible reasons for low titer RPR positive results? So titers of 8 and lower. Start typing in.
We've got 1 vote so far for false positive.
Okay.
Early infection, a vote for prior treatment. Another person saying late infection. Okay. And then serofast is one other option that's come up, or response to treatment. Getting a large spectrum of answers, which is good. So it looks like false positive, early infection, late infection, serofast state, or response to treatment. I presume serofast with response to treatment. It looks like those are the options that people are sending up so far. Okay. Oh, sorry, there's a bunch of other ones. Looking at tertiary infection, rheumatism, maybe they mean rheumatoid arthritis. Yeah, I think those are the options so far.
So what are the causes of false positive RPR results? Those who say it could be a false positive RPR.
We've got APLS, antiphospholipid syndrome, and connective tissue diseases. Another person saying autoimmune diseases like lupus, other viral infections. Paraphysiological states like pregnancy and old age is another vote that's come up. And HIV is another one, and then subacute bacterial endocarditis is another person's voted. Right. Yeah. And then other spirochetal infections. Yeah, I think that's it.
That's great. So active syphilis certainly, and could be very early or late stage syphilis, so tertiary syphilis. Serofast in about 20%, so 20% of patients will have persistent low fixed titers of 8 and lower following successful treatment for syphilis, and this is more likely in those with late latent syphilis who are treated successfully, and lower RPR titers to begin with. So serofast just means that they have a less robust pro-inflammatory immune response. And so they don't decline, the titers will not decline by 4-fold. They may decline by about 2-fold. False positive RPR, certainly in autoimmune disease, in various infections, and some of these were mentioned. Immunization, injection drug use, even pregnancy can give false positive RPR results, multiple transfusions, aging, and generally due to high immunoglobulin levels and circulating immune complexes in some of these conditions. And that's another advantage of the reverse testing algorithm, because we use a specific treponemal screening assay. We can exclude false positive RPR results because if we have a positive treponemal assay result. So some things to be aware of with low titer RPR positive results may be failure to recognize low non-treponemal titer syphilis infections, so low RPR syphilis infections in pregnancy, and this has led to widespread undertreatment. This was in Brazil, where providers inappropriately excluded low RPR titers and thereby failed to use penicillin treatment in maternal syphilis. So in Brazil, they noted an increasing incidence of maternal syphilis from 2010 onwards, and they thought it was multifactorial. So they looked at the predictors of treatment in those attending antenatal care. And they found that the odds of receiving penicillin treatment was higher in women with RPR titers of greater than or equal to 16. So sexual and treatment history is very important when we are considering how to treat syphilis in pregnancy. So there was another article on retreatment, on the utility of retreating serofast patients, that it does not lead to a decline in serological response. They retreated 82 HIV negative early syphilis patients who were serofast at 6 months using benzathine penicillin, and less than 30% exhibited serological response after retreatment and after an additional 6 months of follow-up. So they do not recommend retreating serofast patients. If we look at our national antenatal seroprevalence data for syphilis, this was from the 2019 survey, and they tested 37,000 pregnant women across the country, all provinces, and they found that the syphilis screening coverage was about 93%. It wasn't optimal. And of those who were screened, 17% were awaiting results. And for about 1 to 2%, the results were not in their files. And they also said that there was a 30% increase in prevalence between 2015, which was when the last sero survey was done, and 2019. You can see that the average national antenatal syphilis seroprevalence was 2.6% across the provinces, highest in the Eastern Cape and lowest in Limpopo. Of the 729 women who were reported to be syphilis seropositive, 92% received at least one dose of treatment. So 671 received at least one dose of treatment. The treatment was recorded for 599, and of these 553, so 93%, were treated with at least one dose of benzathine penicillin. And of those who were treated, only about 85%, they could confirm that only about 85% had been treated with at least one dose of benzathine penicillin. So that is far from optimal. This is what the National PMT-CT guidelines say. These were drafted in 2019. It's recommended that all pregnant women are screened for syphilis at the first antenatal visit, and then that this testing is repeated at 32 to 34 weeks for women testing negative in the first trimester. So they recommend use of laboratory assays or even rapid point of care tests. Just to mention, this is slightly inaccurate. There's no such thing as a rapid RPR. Okay. And the rapid syphilis assays generally detect treponemal antibodies, the point of care assays. If we look at early antenatal clinic attendance, again from the 2019 antenatal sero survey, you can see only approximately 1/3 of participants had their first antenatal clinic visit in the first trimester. The vast majority, about 60%, attended in the second trimester, and a small minority, about 5%, in the third trimester. So many women do not present to antenatal care in the first trimester of pregnancy. This is when we recommend screening for syphilis as early as possible, because transmission can occur at any stage of pregnancy, transmission to the fetus. But generally, the clinical manifestations are detectable in the last trimester of pregnancy, because this is when the immune response is developed in the fetus. And most manifestations are due to fetal immune response. What about guidance for implementation of point of care tests at antenatal clinic facilities? This is from a WHO 2017 document. And they say, first evaluate your syphilis screening program. Is there a high coverage? What is the treatment rate? What is the quality of testing? If it's good, leave it. If the current system can be improved, try to improve it. If it can't, then consider implementing point of care assays. But consider the prevalence of syphilis first. If it's greater than 5%, then perform a rapid test, but ideally followed by a laboratory RPR to determine whether a woman should receive the second and third weekly doses of benzathine penicillin. If the seroprevalence is less than 5%, then you may consider employing a single rapid diagnostic test and only performing a laboratory-based RPR if those facilities are available. So what are the recommended syphilis point of care assays? These are the WHO pre-qualified assays. There are dual HIV syphilis assays, which will detect both HIV and treponemal antibodies. So you have first response, SD Bioline HIV syphilis duo. Those are some of the WHO pre-qualified assays. And standalone assay that's WHO pre-qualified is the SD syphilis assay. There's also the ChemBio syphilis screen and confirm, which detects treponemal and non-treponemal antibodies, but this has not been sufficiently evaluated for recommendation, routine use in antenatal clinic facilities. We do have, well, at least the WHO has defined impact and process targets for elimination of mother-to-child transmission of HIV and syphilis. And it's one of the most cost-effective public health interventions, EMT-CT syphilis. They say ideally the antenatal syphilis screening coverage should be greater than 95%, and the treatment coverage among seropositive women should also be greater than or equal to 95%. We have not reached those levels yet. And these targets should be incorporated, or at least the monitoring should be incorporated into the national indicator data set. And this is what we have recommended. Okay. What about congenital syphilis? This is the case definition. That is frequently employed for early congenital syphilis, which is a condition affecting an infant or child less than 2 years with a positive RPR, whose mother had untreated or inadequately treated syphilis at deliveries. What is inadequately treated syphilis? So where the mother did not receive at least 1 dose of benzathine penicillin at least 1 month before delivery. And this is regardless of signs in the infant. So the infant could be totally asymptomatic. Or where the infant or child who has a positive RPR result has any one of the following signs. So any evidence of congenital syphilis on physical examination, or an X-ray of long bones, or abnormal CSF findings, or a reactive CSF VDRL result, or a reactive serum IgM antibody test, such as a fluorescent treponemal antibody absorption assay. And these are some of the signs of congenital syphilis, early congenital syphilis. Remember, the infected infant may be asymptomatic at birth and manifest only 4 to 8 weeks into life. Some of the common signs are snuffles or a nasal discharge, rhinitis. The rash could be macular or papular, and it's usually copper colored. That's how it's described. Affects the palms and soles. May also present with hepatomegaly, anemia, and long bone abnormalities, periostitis, dactylitis, which are evident on X-ray. Manifestations of late congenital syphilis. So this is chronic untreated infection, which manifests in the 2nd decade of life, and often due to chronic periostitis. So the child may have frontal bossing, as you can see, saber shins, saber tibia, abnormal dentition, so Hutchinson's peg-shaped incisor teeth or mulberry molars, and a saddle nose due to cartilage destruction. These are some of the commoner manifestations of late congenital syphilis. If we look at our congenital syphilis notifications, so the NICD started coordinating the NMC program in about mid-2017. The light green bars represent the number of RPR positive results from infants or children who are confirmed to be less than 2 years at specimen collection. This is from the NHLS corporate data warehouse. These are the results. The dark green line is the number of clinical notifications received through the NMC platform. And the dotted line is the trend line for notified cases. You can see the incidence appears to be increasing. So they had a look at these data in more detail. 11% of notified cases who had clinical information available had no evidence of a syphilis test in pregnancy. So this is where the mothers apparently were not tested in pregnancy. 13% of those who were tested were RPR negative at the initial test, and these mothers could have acquired syphilis later in the pregnancy. or had a false negative initial result. For those RPR positive women for whom the data were available, and there were 158, the median time from test to delivery was close to a month, with 43% of the women delivering within 28 days of testing. So they were tested late in the pregnancy, and there wasn't sufficient time to reliably treat syphilis in the fetus. And there's also been a resurgence of syphilis in the USA, particularly among MSM. You can see the blue bars, and also amongst heterosexual females. And some of this has been attributed to risk compensation due to HIV, increased HIV PrEP use, also due to drug use, particularly crystal meth and cocaine. And you can see the congenital syphilis incidence is also increased. So we have had benzathine penicillin supply challenges, and these are ongoing, unfortunately. BPG is still not registered by SAPRA. There are issues with registration, and this is due to quality assurance of the product. There are issues around quality assurance. How do we treat congenital syphilis? I haven't given the doses, but the recommended treatment is aqueous penicillin G for 10 to 14 days. And there are alternatives. So procaine penicillin for 10 days, or cefotaxime in neonates, and ceftriaxone in older infants, also for about 10 to 14 days. So here's case 3. A 44-year-old male presented with symptoms of chest pain, dyspnea, left ventricular failure. He was HIV infected with a high CD4 count and a viral load that was undetectable. He had a history of genital herpes and syphilis in his late teens. On examination, he had cardiomegaly, and an echo and CT scan showed severe aortic regurg and a dilated aortic root and ascending aorta. Syphilis serology, the TPPA and FT-ABS assays were positive. The RPR was negative. What is the diagnosis here?
Okay, we've got a vote for tertiary syphilis.
Okay. But,
yes.
but what is the specific diagnosis? Tertiary syphilis, okay.
Okay, and then syphilitic aortitis.
Right. So this was a case of syphilitic aortitis and tertiary syphilis, certainly, involving the ascending aorta and the aortic valves. Can also involve the coronary artery, because coronary osteal stenosis, and it's due to small vessel vasculitis and endarteritis obliterans of the vasa vasorum that supplies the aortic wall of the aorta. This is due to endothelial proliferation, resulting in dilatation of the aorta, abnormal dilatation. And in the pre-antibiotic era, about 10% of individuals with untreated syphilis would progress to late syphilis. And the management here involves antimicrobial treatment and surgical repair. Yeah. What is the recommended treatment for this condition? A, B, C, or D? Sorry, I might go over time a little bit, Jeremy. I hope that's okay.
Yeah, that's fine. We'll give another 5 seconds for people to answer.
Okay, so most people have chosen option B, which is aqueous crystalline penicillin G, 4-hourly IV for 10 to 14 days. It's actually option A for cardiovascular syphilis. You can give weekly benzathine penicillin G IM for 3 weeks, because this is not infection at a sanctuary site or an immunoprotected site. So IM weekly doses of BPG would be adequate. What about neurosyphilis? Also a manifestation of tertiary syphilis, but can be a manifestation of early syphilis. CNS invasion occurs in up to 40% of early syphilis. But you do not need a lumbar puncture and routine CNS evaluation if there's no evidence of symptomatic neurosyphilis, so no cranial neuropathy or CNS dysfunction. And CNS invasion appears to be independent of HIV infection. And in the pre-antibiotic era, approximately 10% of patients would progress to meningovascular syphilis, so stroke-like illness. And the infection would involve mostly the middle cerebral artery and it would occur 5 to 10 years after infection. Of course, you have general paresis of the insane, so 10 to 25 years after infection. They would present with changes in affect and personality. It could be quite insidious. And then tabes dorsalis, so infection of the spinal cord, even longer, 20 years after infection. This affects the posterior columns and you have shooting pains in the lower limbs, ataxia, bladder dysfunction, and Argyll-Robertson's pupils. Okay. When to test and treat for neurosyphilis? So some suggested diagnostic criteria. So you need confirmation that this patient has been infected. So at least a positive serum-specific treponemal test, plus minus a positive RPR, plus neurological or hearing or visual abnormalities or any other evidence of tertiary syphilis. So these would be indications for lumbar puncture. If there's isolated ocular syphilis like uveitis or otic symptoms without any cranial neuropathy or other CNS symptoms, then a CSF examination would be unnecessary. You won't need to do a lumbar puncture. And then also, if you do have CSF, you could look for a positive CSF VDRL result or CSF abnormalities, cellular abnormalities, increased protein in the absence of other causes. So remember, CSF VDRL is insensitive, only about 50% sensitive, but highly specific for syphilis, neurosyphilis. What about FTA-ABS? Is it done in South Africa? Yes, I think Tshwane Academic Immunology Laboratory offers FTA-ABS on CSF. So this was an article published in Sexually Transmitted Diseases in 2012, and they did a systematic review of the performance of CSF FTA-ABS in neurosyphilis, and they say the negative predictive value of FTA-ABS varied from 60 to 100%. So most texts say that it's a very sensitive assay for neurosyphilis and that the negative predictive value is close to 100%. But they found that there was a heterogeneity of criteria for the diagnosis of neurosyphilis, and some patients had already been treated. So in this article where they found an NPV of 60%, all the patients had already been treated for neurosyphilis. In general, out of the 10 studies that looked at the negative predictive value, 7 showed an NPV of greater than 90% for FTA-ABS. So it's still a useful assay. And we know that the sensitivity is not 100%. You don't get many diagnostic tests with a sensitivity of 100%. So it may not exclude neurosyphilis if the patient is symptomatic and the pre-test probability of neurosyphilis is high. Remember that a negative predictive value is inversely proportional to the prevalence or pre-test probability of a condition. So their conclusion was a negative CSF treponemal antibody test does not exclude neurosyphilis when the clinical suspicion and the pre-test probability of neurosyphilis is high. But I think it is still a useful assay and should be done where possible. So how do we treat neurosyphilis with aqueous crystalline penicillin G, which is expected to cross the blood-brain barrier? Procaine, penicillin, and probenecid could also be used. Probenecid is used to prolong the PENG levels. And an alternative, which has been included in the 2021 US CDC guidelines, and it's also included in the European guidelines, is ceftriaxone. Generally 2 grams daily, IV for 10 to 14 days. And this was a recent retrospective multi-center study. It was done in France. They looked at treatment at 8 tertiary care centers between 1997 and 2017 among adults. And they had strict criteria for neurosyphilis. So patients had to have a positive serum treponemal and non-treponemal assay result, and ocular or otic syphilis, or neurological symptoms and CSF abnormalities, plus a positive CSF VDRL or TP-PCR assay. There were 42 patients on ceftriaxone versus 166 patients on PENG. And they found that there was really no difference in complete response between the 2 groups. Overall response, which was defined as complete or partial clinical response, they found was higher in the ceftriaxone group in both the intention to treat and per protocol analyses. The length of hospital stay was shorter in the ceftriaxone group. And when they included CSF VDRL, which was done in fewer patients, 144, they found that the overall response was also higher in the ceftriaxone group. So their conclusion was that ceftriaxone may be considered a reliable alternative to penicillin G. Ideally, you would need a randomized controlled trial. What about the natural history of untreated syphilis? Infection with T. pallidum leads to or results in growth of organisms at the site of infection and very rapid early dissemination to various tissues, including the CNS. Primary syphilis, we said, develops within about 3 weeks to 3 months. From then, if the patient is untreated in 1 to 3 months, he or she will develop secondary syphilis, and 1 to 3 months later, will go on to develop latent syphilis. 70% of these will continue to have latent syphilis, and about 30% will progress to develop manifestations of tertiary syphilis. So cardiovascular syphilis, neurosyphilis, or gametous syphilis. And in about 25% of individuals with early latent syphilis, so within the first 2 years of infection, there will be recurrence of secondary syphilis, and they will be infectious to their partners. I'm not going to go too much into this because we've discussed this, but many manifestations of syphilis are due to the immune response and due to the early dissemination to multiple organs. And this occurs because of immune evasion. Remember, I said it's a stealth pathogen, and it's able to avoid the host immune response because it doesn't have surface expressed proteins. You can have recrudescence, as we have seen after decades in tertiary syphilis, and reinfection can occur, particularly with different strains. Okay. History of treatment. Mercury was used in the past. Fortunately, we have penicillin, and it's remained exquisitely sensitive to penicillin because Treponema pallidum does not produce beta-lactamases, it lacks transposons, it lacks plasmids that can encode resistance to beta-lactams. We need to consider the long replication time of T. pallidum when we consider treatment, which is 30 hours, the metabolic rate, which is very slow during latency, and the infection of sanctuary sites, such as the CNS and vitreous humor. And this is why we prefer to use long-acting penicillin, because subtreponemicidal concentrations should not exceed 24 to 30 hours. And following a single dose of BPG, we can achieve those concentrations for 10 to 13 days in adults. When we say early syphilis, this dose should be maintained for 7 to 10 days. That's why a stat dose is sufficient. And in late syphilis, the dose should be maintained for 21 days. And that is why we give 3 weekly doses of BPG. The minimum bactericidal concentration is this, and this is what should be maintained. Okay. Remember, I said if you look at the various stages of syphilis, the sensitivity and of non-treponemal and treponemal assays will differ, but they're expected to be very sensitive for secondary syphilis and early latent syphilis. In very early primary syphilis and in late latent and tertiary syphilis, the NTP assays are slightly less sensitive. When should you monitor for treatment response serologically? For primary syphilis, 6 months to a year, and in the later stages at longer intervals. Secondary syphilis, 1 to 2 years, early latent, also 1 to 2 years. And in the later stages, only much later, 3 to 5 years or so. What about neurosyphilis? Generally, you would expect resolution of CSF pleocytosis at 3 months or 6 months, or if you don't want to repeat a lumbar puncture, you could monitor the serum RPR if the patient was RPR positive, and you would expect normalization at 6 months. And that denotes an adequate response to treatment for neurosyphilis. So either 4-fold decline or reversion to seronegativity. And there are various indications for retreatment. So failure of pleocytosis to decrease at 6 months, failure of CSF VDRL to decline by 4-fold at 1 year, or serum RPR to decline by 4-fold at 1 year. I don't know if anyone's experienced this, the Yarish-Herxheimer reaction following treatment for syphilis, but it is acute. It's a self-limited febrile illness, generally occurs within the first 24 hours of treatment, and commoner in early syphilis and also more frequent with penicillin treatment. Management is entirely supported. The European guidelines recommend prednisone prophylaxis prior to treatment with penicillin, but this is not something that is routinely recommended. And it's really a cytokine storm following the release of treponemal lipoproteins with treatment. What about reinfection? It is possible with different strains, but there is thought to be some protection against symptomatic reinfection with the same strain, especially in persons with latent syphilis. But not a lot is known about reinfection, and that there is some evidence that reinfection in persons with multiple previous episodes of syphilis are more likely to be asymptomatic. And these attenuated clinical manifestations are due to an acquired immune response following multiple episodes of syphilis. Okay. How about a vaccine? I'd say this is about 10 to 20 years away. There's antigenic variation of surface lipoproteins, unfortunately. There's phase variation, so some are expressed, others are not at different times, and also sequence variation due to intragenomic recombination. We've also said there's a paucity of surface outer membrane proteins, so there's very slow development of protective immunity. We also can't culture it easily. It can only be cultured in rabbit epithelial cells, and this is only done for research purposes. We also don't know very much about the immune correlates of protection. So really, this is what we need for a vaccine. We need to stop chancre development. We need to stop dissemination to prevent late-stage complications. And we need to overcome the antigenic variation, which I talked about. So the vaccine would need to be broadly protective against many, many different strains. Key messages. Prevalence in South Africa appears to be increasing. So you need to maintain a high index of clinical suspicion and screen at-risk persons, pregnant women, MSM, persons presenting to primary healthcare facilities with signs and symptoms of STI. Need to correlate serological results with good history, so sexual risk behavior, treatment history, and also clinical findings. Syphilis positive persons should receive HCT with linkage to care if HIV positive, or should be offered PrEP if HIV negative and they're deemed to be at risk for HIV. Partner notification and management is important, particularly in early syphilis, where the risk of transmission to partners is high. And alternative treatments to penicillin should be used in case of penicillin stockouts. My key messages. This is the last slide. Which famous people in history may have been infected with syphilis? Okay, any names? Some confirmed, some just speculation.
We've got Al Capone, Mozart.
Yes. Mm-hmm. Who else? Okay, so Al Capone certainly confirmed. Manet the painter, even Idi Amin is thought to have been infected. Scott Joplin, who composed a lot of ragtime melodies in the USA, confirmed to have tertiary syphilis, neurosyphilis, and died in 1917. Henry VIII may have had syphilis. Oscar Wilde, Karen Blixen, out of Africa author, and even Beethoven, though this is hotly debated. And that's the end. Thank you. Thanks for your attention. Are there any questions? I know I've gone over time. I'm very sorry about that, but I had a lot to cover.